Good afternoon. I'm Dr. Anthony Levinson. This is my colleague, Dr. Richard Sztramko, here at McMaster University and part of the iGeriCare initiative. We're really pleased this afternoon to give you our 10th event. The topic is consent capacity and care planning. We'll be discussing some of the essential matters that many family members and caregivers should consider on behalf of people with dementia. Some challenging issues that come up with respect to making decisions around finances or personal care decisions or decisions around accommodation. So we wanted to talk about that. We also wanted to talk a little bit about what are some of the legal approaches to this. What does it mean to be a substitute decision maker or plan to develop a power of attorney document, and what else people should be considering with respect to advanced care planning. A lot to cover in this topic today, so we'll get started with some of the basics, and as always, we will try to cover as many of the questions. There were a lot of great questions and statements that were emailed in, so we'll try to cover as many of those as possible today, and those that we don't get to during the session, we'll answer either in a video extract, or we'll send written responses, or we'll save them for our next episode. So why don't we start with what do we mean by advanced care planning?
So advanced care planning is the process about which you think about what's going to happen in the future, and you contemplate what might be coming down the line for you in the future, and you think about your wishes and what you might want to happen to you. And so this could be with respect to medical procedures or treatments. It could be related to where you would want to live. It could be related to different degrees of intervention. So, you know, we've talked about safety in dementia before, and if people are wandering around, you know, would they be okay with wearing a GPS watch or things to that nature?
So, you know, I guess one of the things that we know in Canada in general is a lot of people don't like to think about advanced care planning. A lot of people don't do advanced care planning. There's an excellent resource which if you're watching us through Facebook, you'll see that we've pinned a resource, and it's a simple website, advancedcareplanning.ca. And some great resources there to think about a topic that many of us spend a lot of time avoiding, which is thinking about what those wishes are. But as they point out, all of us are going to run into problems with maybe serious illness or death at some point. The more that we can help our loved ones, like substitute decision makers, by guiding them with our values and preferences, the easier it can be if they have to make decisions for us at times when we're not able to. So
I think it's easier for people to think about what they would want with respect to financial decisions sometimes. You can clearly lay out who gets what and why that may be the case, and you want to leave your family in a good financial situation. But a lot of times people aren't aware of the complexities of dealing with end-of-life issues with a lack of certainty when it comes about, and somebody can get ill quite quickly. And when nobody knows what they wanted with respect to how they want to leave this earth, it can be a really troubling and difficult time for the family. So the more direction that a family gets, then the less guilt they may sometimes have. Death is permanent, and how you go through it is you can't have a do-over. And so it's challenging for people to actually make such large decisions when they feel uncertainty, and there's lots of medical complexities around what they're dealing with at the time. And
I think with advanced care planning, it's never possible to fully plan out each and every detail, but this can help to give family members, decision makers, a bit of a roadmap. And I think you mentioned, you know, you would like people to be able to follow through on your values and wishes. It's also important to maybe decrease some of the tension when family members might disagree with how somebody should be treated if they have an illness. So let's walk through quickly sort of the 5 points that people talk about with advanced care planning. And again, the advancedcareplanning.ca website is a really good resource for this. But one is just the first step is to think about wishes, values, things that you would like in the future. What's important to you? If you were to get sick and you couldn't make decisions, what kinds of decisions might you want if somebody is speaking on your behalf? The second thing that they talk about is learning. Learn about some of the different medical procedures and what they can and can't do. And I think, this is where it can start to get a bit complicated, but breaking it down into things like, if you were to get sick with an infection, like a lung infection, like a pneumonia, and you knew that an antibiotic treatment could reverse it, would you want that treatment or not? Under what circumstances would you want it or not? I think people are sometimes familiar with the concept of, CPR or cardiopulmonary resuscitation. Like, would people like to have something like that happen? But usually learning about different things like having an intravenous put in for fluid, having dialysis, which is a procedure that helps to remove toxins if your kidney isn't working well. Being put on a ventilator or a breathing machine. So these are all some of the decisions which some people may actually have strong feelings about. Mm-hmm. And in coming up with an advanced care plan, you might say, oh, I never want somebody to do chest compressions on me, or I never want people to use a breathing machine. I'm just too frightened by that. So being able to express that is one of the other points. Decide. And this is a key one. Decide on who will be your trusted decision makers. So the lingo sometimes differs a little bit based on the different provinces, but the concept is usually if you can't make a decision because you're unconscious or too sick, or you have a disease like dementia and you're not capable any longer of making those decisions, who's going to make the decisions for you? Who is your substitute decision maker? That's probably one of the most crucial ones, and obviously then going through what are your values and preferences with that person. Talk about your wishes with that substitute decision maker and your loved ones, and record them in some ways. Write them down. You can even do a video recording, but providing some documentation or record and being able to communicate with that substitute decision maker can really help to guide them to make sure that they follow through on things that you would like. Anything else? I think those are sort of your basic steps. I'm going to argue that probably picking the substitute decision maker is maybe the most important one, but actually then communicating your wishes with them is another important one.
I think too, a lot of this will depend on the various medical conditions that you have and how sick you might be, and what the prognosis or how long you might be expected to live with those conditions might be as well. So involving your primary care practitioner is always a reasonable thing. And then also involving any specialists related to your care who might be more familiar with certain disease processes, so they can really counsel you on what you might expect. And I think too, just stating how complex some of these decisions can be and nuanced. So general guidelines are great. The more specific you can get, the better.
I think as we've talked about previously, in many cases, dementia is more of a chronic degenerative condition. Disorders like Alzheimer's, there's time between when the disease may get identified early on and the person will still be capable early on. But later on, as the disease progresses, and this is the case with other dementias, there may come a tipping point where the person's no longer capable of making decisions. And so it's very important early on in the process of dementia to start doing some of the advanced care planning when the person is capable. So that's probably one of the other important takeaways, is to start this process sooner rather than later. This is an area where there are some differences between the different provinces, but some of the principles are the same. So Richard and I may fall into Ontario discourse sometimes, But we'll try to highlight the principles, and one of the things I liked about the advancedcareplanning.ca website is it did have province-specific guides and resources. So anything else that you wanted to highlight about consent and capacity before we move to some of the questions?
I think there's a few of these general principles that we've put up, but you know, always presuming that a person has capability to decide. Don't presume the opposite. The capacity to make a decision, so the ability to understand the type of decision you're making, weighing the pros and cons and risks related to those decisions may change over time. So at 1 minute you may be incapacitated and sick, but 3 months later you may have resolved a condition that was causing you to be incapable, and you'll be able to make decisions again. It's decision specific, so you might not be able to make complex financial decisions anymore, but you may be able to clearly communicate and understand what you want with respect to your healthcare decisions. And you know, capacity or capability is not related to your ability to necessarily communicate or not. Some people may need to write down what their wishes are, and then it's related to the process of how the decision is made, not the actual decision itself. So there are people that will make decisions that you might not necessarily agree with as a family member or as a physician, but if they had a sound process with respect to how they came to that decision, then that's really what we're caring about with respect to capacity. And then there are complex decisions which can involve laws, so involving lawyers as well as doctors or social workers and family members, and working as a team is always important to coming to the right decision for the individual responsible.
And what I would say is, like, the principles around what we call informed consent are generally similar across jurisdictions, and that is that, you know, in order to make an informed decision, somebody should really be able to understand the information that's being provided and appreciate the consequences related to the decision. So that, you know, we also tend to think about capacity or decision making in different domains. So we are mostly talking about healthcare decision making, which is sometimes called personal care. The decision making around property and finance and banking usually has its own separate domain. And when you meet to decide on who might be your substitute decision makers, or if you decide to produce a power of attorney document and say designate somebody to be your decision maker, it doesn't have to be a one-size-fits-all with a single decision maker in all these different domains. So you might specify that you want this person to be your decision maker for property or finance decisions, and you want this other person to help with personal care or healthcare related decisions. So again, some of those might differ a little bit based on jurisdiction. Some of the lingo is a little different in Quebec, but the general principles are kind of the same. And a power of attorney document is a really good idea. When the person is still capable, you kind of move forward, and it's a legal document that basically outlines who you want to be your decision maker in those different domains.
And I think outlining the difference between a power of attorney, so right now if I wanted you, even though I'm completely capable of making my own decisions, if I wanted you to be somebody who could pay bills for me or do my banking or sell property for me or make investments for me, I could do that. But the continuing power of attorney, so when I become incapable, that's a slightly different proposition. And they may call it different things in different provinces. In British Columbia, they call it an enduring power of attorney. So it's worthwhile to point that out. As well, there are certain power of attorneys that will only come into place after you've been incapable.
Right.
So.
And I think that is important. Some people might be nervous about that, but if you designate different people to help with decision making in a power of attorney document, that only comes into play generally when you are incapable. And as you mentioned, the assumption is that people are capable of making decisions unless proven otherwise. So it's kind of a safeguard from that standpoint. Anything else that, before we get to the questions, anything else we wanted to cover as background on this?
I suppose just getting a capacity assessment. So there are situations where you'll need a formal documentation that somebody has lost their capacity to decide. In Ontario, there are specific designates through the province, through the Healthcare Capacity and Consent Board, that have been approved to do capacity assessments. So if somebody is requiring or has the requirement to be deemed incapable, that individual can come in and do a specific assessment. And then elsewhere in different provinces, sometimes just physicians that are comfortable doing that can do it as well. But just there is a process with respect to deeming somebody incapable that needs to be followed very rigorously. It's
not unusual for physicians who are proposing a specific treatment or investigation to assess, as you said, it's very context specific. For this particular condition at this time, is this person capable? And if they're not, then I need to go to their substitute decision maker or see if they named somebody to make their decisions in a power of attorney document. But it's also important to, in our jurisdiction in Ontario, it's usually separate capacity assessors who would assess for property and finance. And I think that's the case in a few of the provinces. I guess the other thing that is good to keep in mind is, irrespective of whether somebody is or isn't capable of making the decision, if they can no longer provide informed consent, you can still include them as part of the conversation and the decision-making process, even if they are no longer actually capable of providing that informed consent.
Yeah, I love that concept of shared decision-making. You're always providing respect and dignity for the person that may be cognitively impaired, but including them for sure in all the decisions.
Yeah, like supported decision-making.
Supported, shared, yeah, absolutely.
Sure. Okay, well, why don't we move to some of the questions that have been sent in. So here's an interesting one that's really talking about some of the challenging experiences. In the earlier stages of cognitive decline, there's sometimes a difficult dance to play out between the person diagnosed and the support person who's caring for them. Does one not remind and double check as it seems to annoy them? Does the support person just let go and let the chips fall where they may? I guess if there's adverse consequences from that. We have found this extraordinarily difficult to manage, and it affects not only the person with the diagnosis but the support person and family and friends when things can go terribly sideways. Hope this makes sense. Basically, how to protect and yet let one live life to the best of their ability at that time, mishaps and all. So I guess the bottom line is really trying to juggle decision-making, allowing person to kind of have as much autonomy even when the dementia may be affecting their decision-making and there could be some safety concerns. I don't think there's one answer to this. I think you've really summed up nicely that there can be some challenging situations. Safety and risk probably plays the role in balancing that with autonomy, and there may be certain circumstances where the risks to the person and others outweigh the person's autonomy. So,
and I think it's the concept of magnitude of risk. So, is it very unlikely that this person will have some sort of grave consequence, or is it very likely? And that's a continuum, but somebody making a few mistakes on their banking, let's say, and overpaying a bill twice is much different than somebody giving $75,000 away to somebody that they don't know. Or similarly, somebody that left a pot on the stove once is very different than the person who leaves a pot on the stove all the time and refuses to stop cooking. So kind of stratifying it based on the likelihood of a negative outcome, and then intervening only when the risk is happening. I see a lot of patients in clinic where their caregivers are reminding them or talking them through things, but sometimes the person with dementia can't appreciate the complexities of what's being communicated to them. So sometimes it's helpful to step back and observe and take notice of everything that's been taking place, but don't feel like you need to intervene on any possible thing throughout the day that might be going wrong.
Okay. Here was a question. Should a substitute decision maker also need a power of attorney? And I guess what we would say is if the person with dementia is happy with the normal hierarchy or ranking of who would be their substitute decision maker, then it's maybe less urgent that they produce a power of attorney document specifying that. However, in our experience, it's quite valuable with respect to decision making in terms of property and finance. If you're going to a bank and having to make decisions on somebody's behalf, they usually need to see a formal document like that. And it's still useful in healthcare circles if somebody isn't able to make decisions or their decision making is, say, fluctuating because they have a delirium. It's still very useful for the substitute decision maker to be able to provide a power of attorney document that confirms that. And it might be the case that there's more than one person named in the power of attorney in case they can't get a hold of one of the substitute decision makers and a decision needs to be made.
In particular, in the healthcare context, you imagine that the physician who might be taking care of your loved one might have 20 to 25 other people to take care of at the same time. And if there are too many cooks in the kitchen and not enough clarity on who's making the decision or the point person is, then things will always take longer, communication will be less clear, and a positive, timely result may be less likely to happen. So having that document is always great. Somebody brings it in the hospital with them, it gets put on the chart, they get named clearly and decisively as the decision maker, and then the rest of the family can have discussions and be involved, but there's always a leader to that group, which is really important in my opinion.
I think it's the process of getting the power of attorney document is also an opportunity to engage in some of those advanced care planning discussions. Absolutely. As well.
Yeah.
And I think the property and finance formalizing a substitute decision maker for that is quite important. Sort of related to that, if a senior with dementia has granted power of attorney to one of their children who then abandons her, can that power of attorney be revoked? Kind of a complex question. I guess if the person with dementia, they may still have the capacity to change their power of attorney document. Mm-hmm. So if they can, then they should basically do that. But let's say they are no longer capable of making that designation, the dementia is too advanced, then either the healthcare team or the public guardian and trustee might call into question the named attorney in the power of attorney document. So there, basically decisions need to be made, and if that person who is named, the circumstances have changed, and that person can't be accessed, is unavailable, then there are some legal recourses. I would say probably best to get legal advice in that circumstance.
I think so. The public guardian and trustee are responsible for hearing complaints with respect to this issue, so they have to keep documentation with respect to who's been appointed in all of these cases. I think it's a bit easier in the healthcare context because there's a really specific decision-making tree, but so if somebody shows up and it's your spouse or your children or your brothers and sisters, and down a specific tree, down to potentially a friend that's there with you. The financial side, which sometimes we'll see, is if a person has abandoned them but still have access to their financial accounts, then for sure it would need to be revoked, usually through the public guardian and trustee and having maybe a justice of the peace involved. But again, that's legal. We are not giving legal advice here today. You need to deal with lawyers with respect to those things, and the social workers and community care workers living within the community are all well-versed at dealing with the legal system. So.
Here's a question that's come in just now from St. Catherine's. Can you speak to the end of life as the late stage of dementia, are they put into a medically induced coma? My family has been informed that my sister is near the end, but so far they're withholding food and other sustenance. So it's a bit of an unusual question. I guess what I would say is it's certainly not typical that people would be put into any kind of formal medically induced coma as part of certain palliative care procedures. There may be medications given for different reasons or symptom management, but it would definitely not be common to have anything like a medically induced coma. It's also a bit unusual to be withholding food and other sustenance. I guess if the person is no longer interested in food and recoils and doesn't want to have food sort of foisted on them, that's different. But I don't know, any other thoughts or comments about that question?
Yeah, I mean, this is a scenario which comes up not infrequently, and just kind of speaking generally to what you can expect near the end of life. So people's brains stop functioning, and sometimes they do get less interested in food or water, and they're not necessarily conscious or with it or responsive through much of the day. Also, people have challenges swallowing, so they're much more likely to choke on food and get a pneumonia related to that, which is a common cause of death. They're more likely to be immobile, and because they're not eating as much, have more difficulties with their immune system and are more likely to get infections and urinary tract infections and things like that. So in this situation, if it was a medically induced coma and somebody had gone to the ICU because there was a pneumonia, I could see that happening. But I agree, the palliative care instance where they're giving medications to treat an agitated state would be more likely. And the withholding in food and sustenance, if it's at the end stage, as you said, and people aren't interested in eating or drinking, they do get more and more dehydrated, and it might be reasonable just to keep them comfortable.
Yeah.
Yeah.
Actually, this is a good little mini segue, just because we did get quite a few questions asking about some specific end of life, and I think we had talked about possibly having a future live event that's devoted to end of life, but I wouldn't mind just taking a couple of minutes now, just to, because some of the questions that were coming in are what do people actually die of in dementia, and I think that's a really good question, because the dementia itself does not usually lead to the immediate cause of death. But you mentioned a couple of things that people with dementia frequently die from. So I would say pneumonia or a lung infection, sometimes one from somebody who has choked and actually swallowed food into their breathing tubes, which we call an aspiration pneumonia. That would be not an uncommon cause of death for people with dementia. Other types of infections. What are some of the other sort of common things that you've seen in terms of the most common causes of death?
I think that's pneumonia, urinary tract infections, occasionally skin infections from pressure ulcers. You never want to see those things. But also death from unrelated causes, so strokes or heart attacks are also quite common, and they may present slightly differently, and you might just consider how you're going to treat them differently in somebody that has dementia, because you're still susceptible to all the other illnesses that you would be otherwise. I think infections are definitely the most
complications related to falls.
Yeah.
And again, a fall might lead to a fracture. Somebody is taken to hospital because of the fracture, but then develops a complication related to that in hospital.
Absolutely. So it's I broke my hip, I went in for surgery, I became delirious from my surgery. I had more and more medical complications related to the medications. Having an operation or a fractured hip puts you at risk for having, let's say, a heart attack, and then, or a pneumonia. Then you go to the intensive care unit potentially. So it's kind of one of those illnesses that leads to lots of downstream consequences that is more likely to be the cause of death.
Yeah. Here's another question from, sorry.
One thing,
Yeah.
and just sometimes people feel very guilty about the withholding food and sustenance, and just realizing that the brain at the end stages does not require anything. And so you'll treat this number, let's say the kidneys aren't functioning as well, or the sodium's not, it can get quite low in some people or quite high in some people. You'll treat the number and it will get better for a day or two, but then as soon as you stop, it goes right back to where it was. And so sometimes when you're giving intravenous fluids or you feel like you're giving sustenance, you feel like you're doing something, but that person effectively, their brain is dead. And so, not in the technical brain death, definition, but you're actually prolonging suffering in some manner for some of these people. And obviously, depending on your background and your religious beliefs, we always want to be sensitive to people's wishes, but I want to address the issue of guilt, and sometimes you can be doing more for the person by doing less.
Yeah. I think this goes back again to what you were saying about how advanced care planning can actually help to alleviate some of that guilt. Because if you know from somebody's advanced wishes that they say, look, if I'm terminal for some reason, I'm in a coma, or my dementia has advanced so much so that I'm not, participating in day-to-day life and experiencing enjoyment. I don't want dialysis. I don't want an intravenous. I don't want a breathing tube. If when the person is capable, they are able to express these sort of prior wishes and
absolutely.
These are my values, then I think it helps to alleviate some of that guilt about, I should be doing more or giving them a treatment. So,
and always thinking about quality of life and the things that make us human and provide us enjoyment in life. So interacting with other people, having relationships with other people, being able to engage in pleasurable activities, whether it's having hobbies or singing or doing something else. If I personally have lost all of the capacity to do all of those things, then for me personally, my life would not be worth continuing. And if I had the choice between passing away quite quickly from, let's say, a pneumonia, or quite quickly from a heart attack or a stroke, personally, after seeing all of the patients that I've dealt with, I would choose that over a prolonged course where I'm lying in bed, not able to interact with other people.
I think a lot of people would put that down on their wish list in advanced care planning.
Absolutely.
Please, can I have a rapid death without suffering when the time comes? But
and there's other. So just to be specific as well, there are people that have very mild dementia who have a great quality of life, who would say, "Well, I don't want to be put on machines and be made a vegetable." That's a common thing that we hear. And there are situations where I have had patients that have mild dementia that will have a pneumonia or an episode of heart failure where they're quite short of breath and very sick, but it's reversible within a short period of time. You may say, hey, I think it's worthwhile for you to go to the ICU and get support for your breathing. We'll fix your lung issue, and then within 48 hours, you're back
to how you were. Yeah.
So it's, we have to be specific,
Here's another question or statement from Canada, Ontario. I witnessed where a person with dementia was seriously abused by the person holding the power of attorney. How can the patient or the person with dementia be protected at that point? Our team tried to involve legal support, but we did not succeed, and the person with dementia continued to be abused. There was another question, I'm not sure if it's the same person, but basically, how can the patient be protected against a family member that they had trusted who was seriously abusing them in terms of provision of care and finances? I'm going to say that is a very challenging one. In the healthcare field, if we as the treating physicians feel that the substitute decision maker is incapable themselves or is not making decisions that are consistent with the prior wishes of the person with dementia, then we do in Ontario, and I think in other jurisdictions, have the ability to basically say that we feel like the named substitute decision maker is actually not capable. Now that is not a typical or straightforward process. So you do have to basically petition to have that person removed as the decision maker. Again, from a legal standpoint, with respect to property and finances, I think you do need more legal advice, and again, that one could be more challenging.
If you're not successful in the legal realm, you can't be successful. And physicians or family members may support the legal team in that sense and provide lots of documentation on events that have taken place or why they feel like the behavior of the power of attorney is not appropriate. But ultimately, it is a legal battle. I think for finances and property.
I think the other thing that's worth just reminding people about with respect to the role of that substitute decision maker is your job is not to decide on things the way you would want them. You're a representative. So if there are prior wishes that have been declared by the person with dementia, your job as the substitute decision maker is to kind of act in their best interest, and where possible, where you know their values and preferences, make decisions that you think they would make if they were capable. So that's why the advanced care planning or having a good sense of their prior wishes is so important. Here's a question about care planning. When does a person know when to put a loved one in a care center? This person made the decision to have their loved one put in a care center, and then were told that, oh, they should have done it earlier. They experienced a lot of caregiver distress, and they were run down, and people were worried. And we've talked a little bit about the challenges of that. I don't know if you want to say anything about that topic.
Yeah, it's different for everybody. We all have different thresholds in terms of the stress that we're able to bear, and caregiving with somebody that has advanced dementia, I think, is the hardest role that exists within society. You know, being on call 24 hours a day, 7 days a week in some cases, dealing with a lot of sleep, or not very much sleep at all, not having somebody provide you with a lot of emotional reciprocity, positive feedback. I think we commonly run into it when people lose control of their bowel or bladder, when people have significant behaviors where they're becoming more violent, aggressive, agitated, and through the non-medical approaches and the medical approaches, we're not making a lot of headway. When we've put in the maximal amount of community supports with personal support workers, so you have somebody coming into your house 1, 2, 3 times a day to help with everything, and people are still stressed out and not doing well, or we've put in the respite care and they're getting breaks and it's still too much, then we say for sure that it's time.
It's time.
And it's hard to say because this person might have felt bad about themselves if they had done it any earlier. Yeah. So it's easier for people to say, you should have done it 6 months ago.
That's right.
But for a lot of people, they felt like they gave their loved one their very best effort and pushed it to the max.
And the person with dementia may not have wanted to go as well, so trying to respect their autonomy as well as the caregivers.
The one other thing I would add is that sometimes people become so focused on providing care that they're not asking for help. Right? So they're so focused and dedicated on providing the best care possible to their loved one, but it's always the best thing to kind of come up for air, look around, see who can provide you help, talk with your doctor, talk with your case manager, talk with your friends and family, talk with the Alzheimer's Society, and try and get in the max amount of support, and then go back to being a focused caregiver.
A tough question here. Can you speak to medical assistance in dying and dementia? And again, the federal Canadian legislation around medical assistance in dying, or MAID, there's slightly different ways in which each province has implemented it. But I guess the bottom line right now is dementia is really not one of the conditions that can be used in medical assistance in dying. So in every jurisdiction, I believe, certainly in Ontario, informed consent and capacity is crucial. So the individual has to be able to consent. They can't give an advanced directive saying, if my dementia advances to X point, I would like medical assistance in dying. Children and those with mental health conditions, and dementias sort of often lumped into that category, are not considered conditions where medical assistance in dying is appropriate. So this is a controversial area. I think there are many people with dementia or who are involved in the care of people with dementia who really hoped that medical assistance in dying might be available to them. But at this time in Canada, and my understanding is it's across the country, dementia is not an eligible condition for medical assistance in dying. I don't know if there's anything else you wanted to add.
I think in addition to, so there's MAID obviously, or the medical assisted in dying, but then there's also palliative care and nothing. And so there's a big gap in there where a lot of times people will get nothing and no support, but palliative care physicians have such great experience in the dying process, in counseling people on what their options are and providing therapies which can reduce suffering. And when you speak to people that have palliative care involved in their care or in as part of their team, they feel such a sense of relief. And this goes for cancer patients, this goes for dementia patients, or anybody that's, people that have really bad heart disease. Anybody that has a life-limiting condition can benefit from a palliative care physician.
I think...
so don't be scared to ask for it.
Yeah, I think given the amount of people that have asked questions related to that, I think we should do a special live event just devoted to
it's a great call.
Palliative care, end of life, and because I know there were a few other questions. We talked a little bit about it today.
Try and get an expert in palliative care on.
Sounds like a plan.
Yeah.
So let's go through a few other questions that have come in. Here's one that just came in. I'm a power of attorney for a friend who has no family. Power of attorney of finances is an institution or bank. My friend was deemed incompetent of managing finances, has no access to her finances whatsoever. Is this not a violation of her rights? She needs to see a lawyer, but it's not able as she has no funds available. I'm finding it hard to care for her and help her live her best life when we have limited access to her funds. I have to pay and wait up to 30 days for a refund, and it's sometimes not approved. Wow, that sounds like a really unfortunate situation. I will say it highlights one of the important things that we've seen, that is that the value of doing a power of attorney document around property and finance and naming a trusted individual is usually better and more flexible than having what this sounds like the equivalent of a public guardian and trustee management, which is much more inflexible. So I'm not sure what the best bet is here, other than seeing if you could find a lawyer who might take it on pro bono, or actually trying to meet and have the conversation with, there's usually a representative of the public guardian and trustee, and maybe having a conversation about some of the challenges around the finances. A few other quick questions. There was one about flying. It was somebody who sent in, my husband's had multiple mini strokes, has too much iron in his blood, and has a vascular dementia. We're planning to fly to Vancouver for a holiday. Is it safe to fly? Someone advised us that it was dangerous. Now, we can't provide really specific knowledge, but from an educational standpoint generally, if there hasn't been a recent cardiovascular or cerebrovascular event, then I wouldn't have thought the risks are increased. There are some people who are prone to developing deep vein thrombosis or blood clots, and on longer flights that can sometimes be a concern, but I would.
Generally, they've had clots in the past, and you
Yeah,
didn't know
and they're
about it.
managed, and there's usually things you can do in terms of calf exercises or moving a little bit. But
Right.
I'm not seeing a particular.
No, I mean, if there were, it depends on how severe, I guess, the dementia is too, and if there are any kind of behaviors associated with that, and changing time zones, or being able to deal with getting up and going to the washroom, or eating, or can they handle being in an unpredictable, loud environment with lots of stimulus, and how long is the flight? All of these things need to be considered. But again, we can't give specific advice, but those are some things to take into consideration. And
I guess in general, I wouldn't have said,
it's not a
vascular dementia.
It's not a contraindication to flight. Yeah.
Just we'll maybe go for 2 more minutes on a couple of the other shorter questions. My husband thinks he hears music at night when in bed. It sounds as if I have the radio on. He gets quite agitated about this. What causes this? Now, it sounds like he is suffering from auditory hallucinations, and that can be seen in some types of dementia, Lewy body dementia in particular. There are other disorders of hearing that sometimes produce sounds like that, so forms of tinnitus that sometimes sound like that, but this sounds more like an auditory hallucination. It's probably worth consulting a physician about it, and there are some treatments that may be beneficial in some cases, and he may or may not benefit from having a hearing test as well. How do you know when someone with dementia should stop driving? Well, this is a challenging one as well.
There's no hard and fast cut point. So for a lot of things, we'd like to administer a test and see what happens. So sometimes we're guided by pen and paper tests to see which cognitive domains are impacted. Certainly, if there are any significant memory impairments, you need to be able to remember whether somebody was in your blind spot, and remember that the person is coming up to this stoplight in front of you or might be pulling out. Requires a lot of coordination and visual spatial perception. So if you have significant impairments on testing in any one of those domains, then it's concerning. And then self-reported problems with driving or family-reported problems with driving. So if your family's concerned driving with you, then that's a big issue. And if they've stopped driving, or you've become lost when you're driving, or you're limiting your driving because you're concerned about your capacity to do that. So generally, it's some combination of pen and paper tests, clinical dementia rating assessment, and then reported issues with respect to friends and family. If you've had bumps or scrapes on your car, if you've had near misses or accidents, these are all things that we look at. And then there's some times where it's clear cut and we say, no, you definitely should not be driving. There's some times where we say, absolutely, you're fine, continue driving. And then there are some times in between where we say, you know what, you should go to a third-party assessor and do some combination of more detailed pen and paper tests and an on-road assessment, usually by an occupational therapist or somebody who's trained specifically with respect to driving.
I think given the time, I'm going to say we'll wrap up the questions for today. As I said, we'll try to answer some of the other ones either in writing, or we'll take them up at our next live event. Please take a moment to fill out our brief survey. It's been very helpful. Stay tuned. We haven't set the date yet. We're going to take the month of August off, and our next live event will be sometime in September. Please stay tuned to our website and our Facebook page for details. You can also subscribe on iGeriCare.ca on the website. Subscribe for email updates of updated events, forthcoming events, and there's also our subscription learning if you want to get nuggets of wisdom in your inbox weekly. I want to thank the whole iGeriCare team. We always enjoy bringing these live events to you, particularly when we have no technical glitches with Facebook. We try to bring these as free resources. It's important that we maintain iGeriCare as a freely available resource for caregivers. If you can help to support us by a donation through our iGeriCare.ca website, the donate button's in the top right corner of the website. Please consider keeping it going, because we would thoroughly love to keep bringing you live events, and I think we'll plan to schedule one, maybe the September one, related to some of the palliative care topics that we talked about. But on our survey, you have a chance to vote for your favorite upcoming live event topic as well. Funding for these live events is provided by the Canadian Centre for Aging and Brain Health Innovation, powered by Baycrest. Additional support has been provided by the Jerris Centre at Hamilton Health Sciences, the McMaster University, Hamilton Health Sciences Foundation, the Alzheimer's Society Foundation of Hamilton-Halton Region, and our Division of E-Learning Innovation team. Also want to thank the folks at McPherson here at McMaster for lending us the studio. And that survey will be pinned at the top of the comments section. And of course, I would be remiss for not saying that teamwork makes the dream work. So thank you all very much, and we'll see you in September.
Thanks, everyone.